All right, everybody. So we have Dr. Carrie Jones with us today. She is the medical director of Dutch Test, and she is a naturopathic doctor. So welcome.
Thanks for having me.
Yeah, sure. And for today, we are sticking with Operation Smile for my donation. So I think that's a great cause. So that's where today's will be going. And can you just give us a little bit of your background, maybe why you went the naturopathic route and how you kind of got interested in all of that?
Yeah, so I went to undergrad with the intention of going to conventional medical school. I have an undergrad degree in biology and then business, and I was getting disillusioned in conventional medicine. I was volunteering at 2 different hospitals, and I thought, this is not the medicine I'm going to get into. I have to rethink this and figure it out. And I ended up working. I needed a job. I moved to Portland, Oregon, and I needed a job, and so I worked for the naturopathic medical school out in Portland, where I am. And once I realized what it was, I thought, oh, this is where I'm supposed to go to medical school. This is the kind of doctor this is the stuff I believe in. And so that was many years ago. And so I went to school there. I did my residency in women's health and hormones. So I focused primarily in hormones, endocrinology through most of my career. I've been the medical director of 2 clinics that have focused in hormones, gynecology, endocrinology type stuff. And now I'm the medical director for a lab that focuses in hormones. So I always joke that if you have a pediatric question, don't ask me. And if you hurt your knee, don't ask me that either. I don't know. Right. If you're a hormonal mess, I can help you with that.
Awesome. And so, I mean, I've looked into like naturopathic doctors. Mm-hmm. I guess, there's different views on it. It's people who don't know a lot about it and they might think it's maybe like woo-woo. And it's really, I mean, you're very still science-based. So could you just briefly say like what the difference in what you do compared to traditional, a med student and traditional doctor would do?
So when I went to medical school, I had to learn all of the ologies as well. I mean, we had, anatomy, physiology, just all the ologies. And so we had to learn all the pathophysiology and biochemistry. We had to learn the medications and the, how things present, the materia medica, just the way things present, like you guys, and just conventional medicine does. And then on top of that, we had to learn the naturopathic principles, how you view a case more from a systems base. And then approaching problems, root cause, figuring out, peeling back the layers versus just, you have this problem here, take this medication. 8 minutes later, you're out the door. It's more like, all right, let's go back and let's look from a systems, because all the systems are connected, and from the top down, from the bottom up. And what do you need medication? Do you need surgery? Can we do this with diet, lifestyle? Can we use supplements, vitamins, nutrients, things like that? So it's definitely a mix. It's like some people will hate me for saying this, but it's like the original functional medicine.
Yeah. And I love the principles behind it. I think it's a kind of a shame that anybody wouldn't want to approach it that way, that they think let's just throw medicine at it, because obviously nutrition and sleep and all these other things are going to be super important. I think part of it is people's natural tendencies that they want a quick fix. And as you and I were discussing, I kind of right now I'm on a very restrictive diet to kind of help some GI issues. And I remember talking to somebody and they said, well, it doesn't always work, or it doesn't really work for most people. If it did, don't you think everybody would do it? And my thought was like, no, absolutely not. Like, we know a calorie deficit causes fat loss, but tons of people are obese. Right. People definitely would not follow a super strict diet over just taking a pill. Most people do just want to take a pill, unfortunately. And I think some people also just don't know about the alternative. They just go to a traditional doctor, they say take this medication, and they don't know about the other options. Right. At the same time, I would say
people don't want to change either, right? People sleep. I can't sleep at night, and people go, all right, here, take Ambien or take Lunesta or Sonata, and I'm like, well, hold on, maybe if you didn't eat all this sugar at night and drink at night and stay up late and be on your phone and do all this stuff, that maybe you'd sleep better. But it's way easier just to do all your habits and then just pop an Ambien and call it good.
Right, and it is so much easier. And I think to some degree we have to cater a little bit. I mean, we can't tell a patient, well, you're not going to change your diet, so I can't help you at all. I mean, that's,
of course,
these medications exist for a reason and they're helpful, but I do think it's a shame so many people jump straight to them rather than looking for, I guess, healthier or, what we traditionally think of as healthier methods like the sleep and nutrition.
Right. Absolutely.
So, one of the big topics, as we were saying, that's really popular is adrenal fatigue. And that's actually I think for years it's been popular, and I think in our community, in my community, like when I hear adrenal fatigue, I kind of roll my eyes. And so
that's okay. I do too.
yeah. So can you explain what most people think it is and the misconceptions and what we really mean when we're talking about that?
Right. So, well, and adrenal fatigue is sexy, right? Like you can, when you say you have adrenal fatigue, people identify with that because usually they are so tired. So now they have this really sort of sexy name that they can say to it, or, an easy to roll off the tongue name. I have adrenal fatigue. But what they're thinking is that, well, first of all, it's not Addison's. So for people who are listening who have Addison's disease, when you have adrenal atrophy, where your adrenal glands literally cannot make cortisol, that's completely different. This is the part where people are, they're extremely tired, they're burnt out, they're not doing well. And so they get a cortisol test done and their cortisol might be low, not zero, but just low. And they're told, oh, you have all the symptoms and your cortisol is low, therefore you have adrenal fatigue. And they call it adrenal fatigue because they have the impression that the actual adrenal glands themselves just sort of give out, sort of like an ovary in menopause. Like eventually over time, the adrenal glands just sort of shut down and don't make very much cortisol anymore. And while the symptoms are 100% true, I believe people when they say they're tired or burnt out or, whatever they have, I believe them. The concept behind adrenal fatigue is, well, actually it starts a lot higher up because it's everything you do in your life, everything you're exposed to starts in the brain. And so it's the brain's decision, the hypothalamus and the pituitary tells the adrenals whether to make cortisol or not to make cortisol. And so the concept of adrenal fatigue is really more like a HPA axis dysfunction, but that's a big mouthful and not as easy to say. So people will often say adrenal fatigue and then put it in quotes. I'm like, well, you know what I mean.
Right,
I mean, it's a bigger thing. It's a more of a systemic wide thing. I'm like, exactly. Okay, yes, it is. It is more systemic. We just hyper focus on the two little adrenal glands on top of our kidney. And I'm like, no, it's much bigger than that. It's immune and it's brain and it's, in GI, it's thyroid. It's like, there's so much at play here, but the symptoms are real. It's just the quote diagnosis.
So for those real symptoms, how do you go about addressing it? And like briefly, we talked about how some people, they do have a normal level of cortisol, but it's, when it's elevated throughout the day is wrong. And then other people do just have lower levels of cortisol. So how do you go about addressing something like that?
And it depends if it's high or low. So for those people, like you said, first, if they have really high cortisol, their HPA axis is really upregulated. Then we're doing all sorts of calming stuff, whether I'm saying, hey, look, we need to look at the way you manage your job or, your relationship, your school, your kids, what have you, doing things like meditation, making sure you're getting good sleep, just calming stuff. And then there's certain nutrients and herbs that are really just calming in general. There's a really great one called L-theanine. There's certain herbs like magnolia, passion flower, skullcap. I mean, there's a reason that we drink chamomile tea at night. Chamomile, right, is calming. It's a reason why, hops and beer can make you feel sleepy. It's a depressant because hops is calming. And so those sort of herbs are really great for the people who are too revved up. And then on the flip side, for the people who are too low, that I'm trying to figure out, why is the brain downregulating you? So is it a brain issue? Have you had a traumatic brain injury that's affected your hypothalamus or pituitary? Are you on a medication that's really suppressive? So think steroid medications, whether legal or illegal. So the kind of, the gym kind, or like prednisone. But also remember asthma inhalers, allergy nasal sprays, those will all do it. Certain medications like Accutane for acne will do it. And then just chronic long-term stimulation, the brain just downregulates. It's like, okay, I'm over this, for lack of a better analogy. And it will slow down the output of cortisol, or it might convert your cortisol to cortisone, which is inactive. And so you may have these people who have this increased inactivation of cortisol in an attempt to get you to slow down. So we treat that entirely different. So I go for the cause, like what's going on with the brain? Have you had a concussion? Are you on one of these medications? Do you have long-term stress? And then we're using nutrients and herbs and stuff to help the brain, help blood flow, help circulation, help get your cortisol, help communication, get things up.
Okay. And for these things, I mean, as I admitted before we started recording, is some of this stuff is a little out of my wheelhouse, and a lot of the topics I've discussed with other people I'm very confident in my knowledge on. Whereas for some of this stuff, I mean, if you just made up like half of what you just said, I wouldn't really know.
I didn't. I promise. I would not mislead you.
So I can't necessarily, like back up everything. And I like to look at everything through, the evidence that we have. And sometimes, we can't always wait for 20 years of research and 10 meta-analyses to come out and tell us these things. But I'm sure if you're recommending these things, we have data on it. I'm sure you wouldn't just be recommending it. So what is
and some of these things, they're actual part of the biochemistry. Like, think about it. To get you from norepinephrine to epinephrine, which is adrenaline, you need vitamin C. Like it's actually the cofactor in the chemistry equation. So if you are not able to make a lot of adrenaline or epinephrine, if that's one of the reasons you're tired, and you're not eating a diet that has vitamin C in it, you're depleted in vitamin C. Or maybe you're fighting other infections that are requiring vitamin C. It's a potent antioxidant. And so then vitamin C is a good one for adrenal health because it helps you convert norepinephrine to epinephrine. It's actually part of the biochemistry.
Is that something you're just saying, okay, like you look at the diet and you say your diet's low in vitamin C? Are you testing vitamin C?
Usually diet for sure. I always go into diet with people, find out, what they tend to eat or don't eat, as a lot of people will avoid food groups for whatever reason, or things like, gluten, or just, I don't eat carbs, or I don't eat soy, or I don't eat dairy, or whatever they don't eat.
Right.
And then a lot of times it's symptoms. I do testing on them, depending on the person. And I'll say, all right, we're going to add in some extra vitamin C as part of your protocol. If you're low, especially depleted.
Are you measuring, I guess, like how often are you measuring these levels, the cortisol first throughout the day? Are you measuring multiple times throughout the day?
I do measure throughout the day, yeah.
Okay.
Because I'm looking for the circadian rhythm. So in a blood draw, it was, when you get your blood draw, it's a combination of the cortisol bound up to cortisol binding globulin, and what's free and available. So if you get a cortisol read in the morning that's 15, you don't know if what percent that cortisol is free and what percent is bound up. And then most people don't want to get their blood drawn throughout the day. They don't like to get needles stuck 4 times in the day. So we have to find alternatives to try to see what their cortisol is doing, because we're looking for that circadian rhythm. And the circadian rhythm, they should be high in the morning, get your butt out of bed, get you going. It's called the cortisol awakening response, which is also super important for autoimmune, super important for blood sugar regulation. It's anti-inflammatory. And then you want your cortisol down at night, because that's when your melatonin comes out. So you want to sleep and, rest and heal. You want your lymphatic system to turn on in your brain. So you want your cortisol nice and low when you go to bed.
So when the timing's off, is it just a matter of let's get your sleep habits better?
Usually, yes.
Yeah.
That's definitely the easiest and the cheapest to start with, for sure.
And are there people who that doesn't work for? And if so, where do you go from there?
Yeah, and it also depends on their day. So it depends on their schedule. So if they're night shift workers versus day shift workers, if they get up at 4 a.m. versus people who get up at 7 a.m. So it really sort of depends on what their normal schedule is. But sleep is what I focus on absolutely first. Are you going to bed on time at a decent hour? Are you off your electronics before bed? Because that blue light goes into the to the eyes. It hits the SCN, the suprachiasmatic nucleus in the brain, and mimics sunshine. So the brain goes, all right, well, I guess it's light out. We should put out more cortisol. And we don't want that. So getting off electronics at night, winding down, dimming the lights, what have you, and trying to get people, to go to bed. And that often, if you can reset your sleep, you can often reset your whole circadian rhythm. But then on the flip side, for those folks who can't get up in the morning, in order to get up, in order to stimulate your cortisol awakening response, you need light into your eyes again. So at this time of year, I'm telling people, either if you live in a place that has sunshine, when you wake up in the morning, first thing, open your blinds, look at the bright light outside or go outside. And if you look, or if you live in an area like I do, Portland, Oregon, which is currently gray and raining, then buy those full spectrum lights. Buy either the box that there are these boxes you can buy that sit on your desk, get a full spectrum light bulb to put in one of your lamps in your room and turn it on in the morning. Because when you get that bright light, it triggers the hypothalamic pituitary adrenal, like, oh, it's the morning, let's make cortisol and gets it up, and it helps you retrain just by going to bed properly at night and getting proper light exposure in the morning. I mean, that's how our circadian rhythm is governed, is all through light and dark. And it's so cheap. It's so easy.
So I haven't looked into those boxes too much. I think I might get one because right now I get up at around 4:30 or 5, and it's not light for probably 2 hours or so after that. And I definitely have some like problems staying asleep, and just I guess throughout the day, you know, it's always been a little like foggy. So there's some decent research on those boxes that it seems to. Okay.
Yep, definitely. Because they're sun mimickers. And so the light that they emit mimics the sun. And that's what you're trying to get in your SCN in your brain, that light to trigger it to go, all right, make CRH. And then that tells the pituitary to make ACTH. And then you make cortisol.
How much exposure to those is usually recommended?
So you don't have to stare directly in them. So you don't feel like you need to blind yourself every morning. But you just need to have it on around you. So if you're, you know, like making breakfast or getting ready for your day, and the boxes are usually portable, you know, just put it on your kitchen counter and then move it to your bathroom counter, and then, you know, sort of take it with you like you would take your cell phone, and just have it, you know, and have it on, because you want that light, that bright light that your eyes can see it. You don't need to necessarily stare at it. But I do know people in my old office, you know, we would have it right on our desk. So as you were sort of in your office, sort of charting or doing whatever you're doing, people would have their, we call them happy lights. And so they would have their happy light on, and they would have them on for a couple hours in the morning, just to really, especially where we live, which is really sort of gray and dark for most of the year, have them on a couple hours in the morning.
And when do you usually try to start getting away from the blue light? Like 3 hours before going to bed, or is there?
Yeah, so I think research recommends at least an hour before bed. So if you go to bed at 10, you know, definitely by 9. But because where we are in the United States in our season, we're getting dark around, you know, 4:30, 5 o'clock at night. And so historically, of course, humans follow the light dark cycle, and historically we would start to, you know, wind down, go to bed when it got dark outside. So I tell people when it's 5 o'clock is way too early, but like consider switching or dimming the light on your cell phone. Consider you can actually change the background of your cell phone to red.
I was going to ask about that. Yeah. So those are kind of legit, that function.
Yeah. Well, I'm hoping so.
Yeah.
I do it. So a couple hours. So usually somewhere around like 6 or 7, I have an iPhone, and iPhone has you know, like quick buttons, and so I have a quick button that'll switch it to red around 6, 7 o'clock at evening, and then I have the blue light blocking glasses. So I have those kind of orange tinged, lovely glasses that I wear at night. And I think I also have I have no affiliation, but I have an Oura ring. And so I track my sleep every night. And the more I wear I remember to wear my blue light blocking glasses as part of my routine, the better I sleep.
Okay.
The more deep I get, because I'm getting more darkness.
Are you familiar with the, I think it's called Flux or Flux for the computers?
Flux. Yeah.
Okay.
Yep.
Yeah, I have that as well.
That as well. Yeah. And they have it for the phone.
Okay. Yeah,
I just changed my whole
more or less
screen.
the same thing.
Yeah.
Gotcha. I'm not really familiar with the rings at all. How accurate are those? Like, how does it work?
Like people will have like a Fitbit or something, or they'll have the, you know, an Apple Watch. I actually have never ever had those. I like the ring just because it's super easy for me. But so I have nothing to compare it to. Unfortunately, I can't say, well, just to say this. Now my ring says that. I don't know. But what I do like is that it absolutely seems to track pretty well. Not 100%, but probably above 80% of my sleep. Like when what my temperature changes through the night, my heart rate seems to match up when I just do my heart rate the old-fashioned way.
Yeah.
And then check the ring. Respirations, and then when I'm in sleep, REM and deep, and then if I wake up. So if I like wake up, you know, 3 in the morning or what have you, my ring seems to catch it and will show me. It changes on an app. It'll change color. The wake up.
Okay, it's connected to an app.
Yeah. So, and you can turn it in airplane mode through the night, much like most devices. So I just airplane mode it at night. It still records it, connect it in the morning, and then I can see my little graph. And I can for sure see, which I'm sure like people who have other different kinds of trackers, I know what screws me up. You know, I know if I'm up too late, if I know if I have sugar before bed, for sure if I have alcohol, even a glass in the evening, my sleep is completely screwed up.
Gotcha. Yeah, I
So
wasn't sure mechanistically how it works. I've not really looked into it. Like I said, is it just based on your heart rate and temperature,
it's
or is
heart rate, temperature, and heart rate variability. So
okay?
I'm just getting into
Interesting.
heart rate variability as a marker of your ability to stress resilience, your ability to
Right.
handle stress. Yeah.
Right.
So the
Cool.
better
Cool.
sleep you have, the better your heart rate is, and the higher your heart rate variability, which is a better stress marker.
Cool.
Yeah.
When I was younger, every night would finish with some sort of dessert. And when I mean younger, I mean like even a year ago. I would always like, not necessarily dessert like ice cream, but maybe like a homemade ice cream. It's like something that had a reasonable sugar content. Mechanistically, why is that going to affect our sleep?
Well, sugar. So sugar, but I meant liver. When your liver is and your pancreas are processing the sugar and you're getting the blood sugar fluctuations, most people will wake up somewhere between 1 and 3 in the morning. So if they have a glass of wine, which is high in sugar, or they have some dessert before bed, then they'll get this sort of pancreatic liver thing that happens. And sure enough, between 1 and 3 a.m., they'll wake up as a result of it. And if you skip the dessert before bed and if you skip the glass of wine before bed, people say, oh my gosh, I've slept so much better. I'm like, right, because you're not working so hard to balance your blood sugar, your insulin, your detox, if it's alcohol, through the night.
So you're talking, I mean, the amount in wine isn't that great. So you're talking even a little bit of sugar could
When
really do
when
that.
you combine the sugar and wine, when you combine the sugar with the alcohol, then it's a double whammy.
Interesting. Okay.
Yeah, the processing of the alcohol.
Cool. So obviously, a lot of people use melatonin for helping them sleep. So I personally have not noticed it help me sleep at all. I'll get in a bit as to what I did find it helped me. But do you find most people it helps with, and when do you tend to use it?
Yes, I'd say it's probably 50-50. So remember, most of melatonin is made in the GI tract, and very little melatonin is made in the pineal gland, but it's the melatonin in the pineal gland that really helps set the circadian rhythm. And so the actual taking of melatonin, like it doesn't work at all for me. I've taken melatonin physiologically, we don't make very much melatonin out of the pineal gland. It's like 0.2 or 0.3, but what we do take as supplements, they're generally 1 milligram up to 5 milligrams, and sometimes you can take it a lot higher. And so there is some debate, like maybe we're taking way too much, we're over melatoninizing ourselves. But I've tried everything. I've tried the 0.5 all the way up to 3.
So no effect for you, though, really.
No effect for me. But melatonin production is not my problem. When I measure my melatonin, that's not what's it for me in sleep.
Is that a blood test that you're using?
It's not. It's a urine test. You catch there's great research that shows the melatonin that's produced turns into a metabolite that gets excreted in urine testing or in urine, and so you pick it up on urine testing. And so you do it in the morning, so it'll catch your melatonin that's through the night and then store it in your bladder, and you urinate it out and catch it.
Gotcha.
So and mine's always fine. So I'm like, dang it.
Yeah, it's like you almost want it to be bad because then it's like, here's a problem I can fix and get better.
Right,
So
exactly.
like
Especially when I cross time zones. I've even, when I travel a lot for my job, and even then people are like, oh, take melatonin, they help you acclimate. I'm like, nope, it doesn't work.
All right. Yeah, unfortunately, it hasn't helped me for that. But what's interesting, I did notice helped is, so for my GI issues, I tried a keto diet, and I'm definitely not like a keto zealot or anything like that. And it makes it harder to get in a lot of calories, but it did help me from a GI standpoint. But I will say that I started getting acid reflux, and I've actually read a lot of people do keto to help acid reflux. But I've never had noticeable acid reflux in my life. And I started getting to the point that it was pretty bad. And I didn't want to go on anything like omeprazole, especially long term. And then I just started reading about people using melatonin. And I had never heard of melatonin for GERD or anything like that. But I read a few studies where people with acid reflux had roughly half the levels of melatonin in their blood compared to, I don't know if it was blood or saliva, but however they measured it, it was half the levels. And so I've been taking it now for about 3 weeks, and no more reflux, actually.
That's amazing.
So, yeah. I don't know if you've ever used it for that, or if you've heard much about that.
But and I don't know the mechanism behind it. I don't know if they said that, but one of the reasons melatonin, much like serotonin, is made in the gut is that, like I said, it's a huge antioxidant for the gut, but it helps quite a bit with peristalsis and moving things along. So it's entirely possible it's helping move things down and out faster, down into the intestines faster versus even giving it a moment to hang out and then worsen reflux because of the sphincter there.
Yeah.
But I don't know the actual like if there's a sphincter mechanism that melatonin has. I don't know that.
Yeah, I think when they compared it to omeprazole, they both had very similar efficacy, but the difference was it caused the sphincter to close more so.
Melatonin did.
Yeah, then the omeprazole didn't have any effect on that.
Of course.
And so when they looked at acid levels in the esophagus, they were still high to some degree with people with omeprazole, but it was lowered throughout with, or no, sorry, I said it the opposite way. Omeprazole did lower the amount of acid, which is obviously how it works.
Right.
But melatonin, I thought, was a better way to actually address the problem, which is that the sphincter wasn't closing, because this way you're still digesting everything just as much. You're not losing that acidity in the stomach. You're just preventing it from getting it where it shouldn't be. So
absolutely,
which is
what's interesting about omeprazole, because like the mechanism of action, as you know, it's proton pump inhibitor, right? So it like lowers acid levels, but what they find is that it's not always that's not the problem. It's the problem that the sphincter won't close. So the normal production of acid is coming up and really obviously irritating. And so it doesn't ever address the cause, is I guess my point. Not often. You want to improve that sphincter tone so the door closes completely and then the acid can just stay in the stomach and do its job.
Right. And that's kind of going back to our first topic with the naturopathic versus like the traditional medicine. That's something that just annoys me because, like I said, I'm heavily research based in my recommendations, and I like to be very scientific. But when I see something like that, and I see that I think I came across at least 3 studies showing melatonin compared to omeprazole and showing at least similar effects. But when I ask any traditional medical doctor, what do you do for acid reflux? I prescribe a PPI. I've never ever heard. I never even until like a couple weeks ago even really heard about this melatonin for GERD thing. It's just not. I've never learned about it in school. It just wasn't brought up. And my thought is like, why? Why wouldn't anybody would probably rather take melatonin with minimal side effects compared to a PPI, which we know for years and years and caused a lot of issues. So
a lot of issues with nutrients and minerals and vitamins, and for sure.
Yeah. So I don't know, just a little frustration, but.
Yes, that's a good reason why I like to be a naturopath doctor, because
it's there's, especially like endocrinology in general, there's so many different pathways and so many things affect so many other things. And one of the reasons I wanted to have you on is just because it seems almost insurmountable when you look at at times when you look at where a problem arises, and if it's not this one quick fix, then how do we do it? And so thyroid is one that I think is really interesting. And again, not to completely rag on traditional doctors, because I think a lot of them are great, but one of my first experiences with seeing this person doesn't really know what they're talking about was when I was only 19 or 20 years old. And so, being into lifting or bodybuilding or whatever at a young age, I wanted to kind of just always get things checked. And my thyroid was a little low.
Like your TSH?
Well, so that was the thing he just did TSH, and he said your TSH is normal. And I looked, and my T4, my free T4 and free T3 were below normal. And he's telling me how, no, your TSH is normal, so it's fine. And I'm like, how? The TSH is kind of like the start, right? And you're looking at that, but the TSH isn't the active thyroid hormone. So you're telling me that my thyroid's normal when my active hormones are low. And my TSH is, I guess fine, although the range at the time was, I think, a wider range than I think it's been narrowed a little bit now.
Yeah.
But anyway, just looking at that, and I was like, it just seemed very odd to me, even as an 18 or 19-year-old guy, that you're telling me that's normal when you're only looking at an indicator. And then we did eventually, I convinced him to try levothyroxine. And interestingly, he put me on 150 micrograms.
That was your starting dose?
Yeah.
Wow.
And TSH instantly was almost 0, 0.04.
That's why I'm shocked.
And then T4 though was normal because that's what I was taking, but my T3 was still low. And so I kind of want to get your insight on this, because
I was just going to say, do you want to know why?
Well, so I have a theory that so I kept taking more T4 because I was like, okay, and I literally got up to 300, maybe more micrograms. Yeah. And T3, it never, T3 was, it doesn't matter how much I took, T3 never increased. So I think I know what you're going to say, and I'm not sure. So go ahead, and then I'll.
I go first.
Yeah.
And this is what I find also really frustrating. I think lots of practitioners, naturopathic included, I think we just forget the biochemistry of how thyroid is made. So TSH, thyroid stimulating hormone, is reflective of the amount of T3 that you have in your pituitary, only your pituitary.
Mm-hmm.
So if your pituitary is super happy, you have good T3 levels in your pituitary, then your TSH will be a, quote, normal level. But what happens then is that you make your thyroid makes T4, which for people who don't know, T is tyrosine, 4 iodine. So T4 is a tyrosine with 4 iodines attached to it. So if you're not getting enough tyrosine in your diet or iodine, then you're going to have thyroid problems there. But T4 then has to convert into T3 in your periphery as well. Mm-hmm. And if you don't convert into T3 in your periphery, and there's a million reasons why that gets blocked, it can then go to something else called reverse T3, which is inactive, then that doesn't register back in the pituitary, because the pituitary, the things that decide this are called deiodinases, and the deiodinases in the pituitary are different than the deiodinases in the rest of the body. So when people have all the symptoms, I'm cold, I'm constipated, I'm gaining weight, my brain is sluggish, my hair is falling out, whatever, I can't get pregnant, but yet their TSH is normal. I'm like, right, because all those things are out in the periphery, right? They're out in your fingertips, your toes, your hair follicles, your uterus, your skin, whatever is peripheral. And so you're not converting from your T4 to your T3 like you should out in the periphery. And so we prescribe T4 medication, levothyroxine or Synthroid, and we get taught by people, doctors, pharmaceutical companies, the body will automatically convert it to T3. And it turns out, like I said, there are a ton of reasons that it would not convert. And so you can either address the reasons it's not converting or add T3 in as well, which is called liothyronine or Cytomel. Mm. My assumption for you is that your pituitary was fine.
Yeah, well, so you went into more detail there, which is good. So my initial thought was you'd talk about reverse T3, and as I was reading about it, I think, like I said, I was probably around 20 now when this was prescribed, and so I looked into reverse T3, and there was that site like Stop the Thyroid Menace or something like that. And so I was like, oh well, my reverse T3 must be high. But I tested it like 4 different times, and it was always kind of normal. Now, I don't know if it really fluctuated within normal, but it was always pretty much like the center of normal. So that really confused me, because I was like, okay, I'm taking this T4, and I don't have high levels of reverse T3. So how do I not have high levels of T3? But it sounds like you're saying there's other...
Yeah, you're just not converting at all. Yeah. So a big reason that you would make a lot of reverse T3 is if your cortisol or norepinephrine was high, then your body will mechanistically push more into the reverse T3. But there's actually a whole lot of reasons that you would just not make T3. So if you're missing certain nutrients like selenium, if you have women and men too, high estrogen, low DHEA, if you have high leptin, there's a whole variety of reasons that the body, metals, environmental toxicants. I mean, there's a lot of research if you look at peripheral hypothyroidism that T4 doesn't convert into T3. And unfortunately, in this day and age, we're getting those things more and more. More and more people's systems are broken or breaking or not on their A game. And so their ability to convert is not that great. Now, it's fine in the pituitary because the brain, not always, of course, but this is where it gets confusing. My TSH is normal. My TSH is normal. I'm like, well, that means you have T3 in your pituitary, different deiodinase. We got to look out in the periphery.
So what do? Do you just give the T3 as well, like Cytomel?
Like I said, you can just add in the Cytomel with it, or then try to find the reason that you're not getting that conversion. So going down the list of things that block conversion and work on those. So if you're working with a woman and she's estrogen dominant, meaning she's got way too much estrogen sort of throughout her cycle. I understand estrogen fluctuates, but maybe fluctuates bigger, stronger, higher than it should. If you've got somebody who has really high leptin levels, they're leptin resistant on fasting testing, just things like that, then you're going to address those things, and that can help. If she or he are deficient in selenium, or iron. Iron's another one that will get in the way of conversion. And how many anemics or sort of suboptimal iron people are out there? A lot.
Right.
And so that'll all affect your T4 to T3 conversion. So you can try to find the cause, or obviously the quick shortcut is just to give T3.
Yeah. Well, I mean, that's kind of goes to what I was saying before about how complicated. I mean, we're talking about one thing here. You know, most people have more than one thing wrong with them. So you have one thing, and you've got to find, okay, it could be these 15 things that are causing the problem. I mean, I don't, a lot of respect for you to take the time to be able to go through those things.
Well, that's the thing, right? I mean, that's the big problem, is that the medical model we have right now doesn't allow for practitioners to sit and like really go down these rabbit holes with people. We've got about 8 to 15 minutes in a traditional visit, and that's about enough time to say, all right, let's look at the labs real quick and be like, you need this prescription, here you go, nice to see you, when you're out the door. So I don't necessarily blame doctors. I think just the medical model is, if you're seeing 30, 40, 50 patients a day, you can't go down rabbit holes. You just can't.
Yeah. Unfortunately, I was going to say it kind of goes back and forth, because the model is we see so many patients, they just don't have the time. And then at the same time, it's probably frustrating as a doctor. Like, let's say you really were just, what, I really care about this stuff, and I'm just going to sit down with the patient. How many of your traditional patients are going to actually then listen to those recommendations? If you have a patient who comes in just when there's a problem, hey, I think I have thyroid problems, and you say, well, okay, here's what we're going to do, and you give them this whole plan and all these habits that change. It probably gets frustrating when you give these recommendations and nobody listens to you.
I know.
I mean, I think the stats show that even, I don't remember the percentage, but some surprisingly high percentage of people don't even fill their prescriptions after they go to the doctor for the problem. So if they're not even willing to fill the prescription, it's a tough situation.
Totally tough. Yeah, it's tough all around. Absolutely. And plus, if thyroid is sort of deemed as this sort of magic pill that will help with weight loss and metabolism. So most people they don't want to sit and listen to all the suggestions to try other ways to help. They're like, well, just give me the pill because I want to lose weight and I don't want to have to work at it. Like, okay, not how it works. It's not magic. If it was magic, then everybody would be on it. But
speaking of which, do you find that a calorie deficit itself prevents people from converting as much T4 to T3 supplementally?
It's a survival mechanism. Think about it. If you're in a calorie deficit, if you're in a starvation, and there's research to show this, then it's to protect you. It will slow down T4 to T3 conversion. Because it's sensing, oh, we must be in starvation, and I need to protect that. The thyroid's a master gland, and it needs to protect and slow everything down, so that, because it doesn't know how long you're going to be in starvation, and the brain consciously, we know we're trying to lose weight, but the thyroid doesn't know the difference between I'm trying to lose weight and it's true starvation. I don't have food around me. It doesn't know the difference, and so it will slow down that conversion, and subsequently there goes your metabolism.
Right. Well, and then, that was my experience as well, because I know some people think that it'll just help you lose all this weight. I think if you were to take a ton of T3, it would. But in the bodybuilding fitness world, there are certainly people who abuse these drugs and just take tons of it. But I don't know if there's really any amount of T4 you could take that, if you're in like a severe calorie deficit, that's going to convert, because like you said, the body's just going to prevent it from happening.
Right. Yeah, absolutely. And then if you do, as you know, if you're taking or getting way too much T3, now you've pushed yourself into hyperthyroidism, which has a whole host of risks. I mean, oh my goodness, it can really affect oh my gosh, your heart, and just, it's so much stuff that you have to be really careful that you don't throw somebody into a hyperthyroid storm.
Yep. And I know you're obviously very familiar with estrogen, and that's not something I've looked too much into personally, although I know it does.
Probably don't need to.
Right. And for the most part, a lot of guys don't. But I've looked a little bit into DIM. I don't remember the
diindole methane.
Yeah. So do you find that a useful supplement? Because like I said, I've tested a lot of things on myself, and I've tested seeing what my testosterone and estrogen levels were. and I like things I can test and
Right.
so, or measure, I should say.
Right.
And so my understanding, which is not so great on DIM, is that it doesn't necessarily lower estrogen. It converts a more harmful form to a better form. You can tell by the way I'm asking this question that I'm not overly familiar with it. So maybe
No,
you
no,
can
it's
enlighten
good.
me.
I will tell you, this is probably my absolute most favorite subject ever to lecture
Okay.
about. So this is a good one. So DIM, diindolylmethane, actually, so the brassica family, your broccoli, your kale, your cauliflower, Brussels sprout foods, they contain indole-3 carbinol, I3C, which you can also find as a supplement. When indole-3 carbinol hits acid in your stomach, it needs acid to break apart. One of the main things it breaks into is DIM, diindolylmethane. DIM can take your two main estrogens, your E1 estrone and E2 estradiol, of which both men and women have, and it will push it in phase 1 detoxification towards the healthier pathway. So in phase 1 detoxification, you can go down there's a 2 pathway, a 4 pathway, and a 16 pathway. The 2 pathway is considered the healthier, less carcinogenic pathway. Your 4 pathway is considered the more carcinogenic pathway. And your 16 pathway is considered a proliferative pathway, makes things grow. So great for bones, bad for boobs, bad for heavy periods, clots. So you're trying to divert yourself away from the 4 and headed towards the 2. So it's good for a woman or a man who has a lot of estrogen in circulation, is if you take DIM, you can drop your E1 and E2 out of circulation and push it towards the 2 pathway. But you do have to be careful on those menopausal women who already don't have very high levels of estrogen. They're menopausal, so they have menopausal levels. And if they're favoring the 4 pathway, which is more carcinogenic, not guaranteed, but more, and then you put them on DIM, there is a chance she will call you and say, my hot flashes are back, my night sweats are back, my brain fog is worse, I feel more depressed. Because what you've done essentially is drop her menopausal levels of estrogen even lower. DIM is not a cure-all for everybody. You have to be careful. Now, DIM really only affects phase 1 detoxification. If your phase 2 detoxification is not good, then you have not addressed the problem. Or you may feel better for a while. Your estrogen symptoms may decrease for a while. But phase 2 is where you neutralize all these phase 1 metabolites. And so you have to make sure you know the difference between your phase 1 and phase 2 because the treatments are different. The way you address it is different.
Okay.
So DIM is used kind of as this panacea for estrogen, but it could make problems worse if your phase 2 is not that great.
Okay. Because I've heard people say that it'll kind of more regulate estrogen. Like that's where I was kind of like wondering. There's like, oh, if it's too high, it brings it down. If it's too, if it's
it doesn't.
Low,
it won't bring it up. Nope, it won't bring it up.
Okay,
It'll
so
only bring it down. So that's not true. Yep, that's not true. But it's also known. There is some research that it's an anti-aromatizer. So a lot of men like it because it blocks the conversion to a degree of testosterone to estrogen. It's obviously not as strong as something like an Astrozole, the medication, but it is helpful for that man who's mild. And then it will help lower estrogen. So it does do that. But again, if you can't neutralize it, then you when your body makes a 2 or a 4, when you go down that pathway, they can continue on to something. They can become something called a quinone with a Q, which is a reactive oxygen species, which is pretty damaging. We don't want that, and it can bind to DNA, and the 4 pathway will actually bind to DNA, and it breaks out and causes holes in your DNA. And of course, we don't want holes in our DNA. And mutation risk increases. And that's why it's called the carcinogenic pathway. But my point is with DIM, if you're pushing the 2 pathway, which is great, that's the pathway you want to push, but you can't then get it out through phase 2 and on to phase 3, then it can go backwards. It can sort of go back and become a reactive oxygen species. And it hangs out in your DNA, and it's wrong as it hangs out in your DNA. So you have to wait for your DNA repair system, which is called DNA excision base repair, to come in and fix it, which increases the risk of mutation. So there's all these sort of DNA related things that we have to be careful with. So yes, DIM is great, but definitely be careful. You've got to work on phase 2. And then of course, phase 3 is when it gets out through your intestines and out in your stool.
Right.
And there's all things that can go wrong there too.
Yeah. Again, complicated.
Very complicated. I know. So I tell people, and as more people are getting into SNP testing, and genetics, genomics, in phase 2, you're looking at your COMT, your COMT. That's the enzyme you're looking at. So for people who are, and I saw some of your speakers you've already been on have talked about, genomics. And so if you know already that you have a slow COMT, that's your phase 2. So that means you're going to have a slow ability to get you from your phase 1 estrogen into the neutralized form, and you need to support that enzyme, help make it go faster. Yeah.
And you were saying, because I had mostly heard it preventing or causing conversion of one type to another, but you're saying it is inherently an aromatase inhibitor as well.
There is some studies that I have seen that, that I have seen that. It's primarily known for its ability for phase 1 detox of estrogen. But there are some studies that say that you can use it. It has a mild anti-aromatizing effect.
Okay. Yeah. So, and that's not,
which is why men like it, which is why bodybuilders like it, because they want
that. Right. And I think it's interesting just because, like, obviously as you get older, a lot of men start converting more testosterone to estrogen. Yeah. Something I was thinking of, though, is because, like I was saying before, I like to measure things. And so if it's just from one type to another, I was thinking if you measure total estrogens, you might get a similar value. But if you were to measure something like maybe like estradiol specifically, you would probably see that change then if you were taking DIM.
It should go down. It should go down. And DIM generally works rather quickly. It doesn't take months to kick in. Usually it takes days to weeks. And so what it does is it takes your estrone and estradiol and it converts it into 2,4 or 16 hydroxyestrone or 2,4 or 16 hydroxyestradiol. And then when it goes through COMT into phase 2, it becomes methoxy. So 2-methoxyestrone, 2-methoxyestradiol, what have you. And so you can test those markers. You can test your hydroxy and your methoxy, and you can watch them hopefully go the right way and go down. So, they are testable.
Interesting stuff.
Yeah. Cool. Yeah. And you can test your COMT, of course, right? People are getting SNP testing. They're doing their DNA testing. And then you can know if you're a COMT++, you're a slow person.
Slow person.
You're a slow person when it comes to estrogen, but you're also slow in getting rid of your dopamine, your norepinephrine, and epinephrine, because COMT and MAO are what help you. Those enzymes help you degrade your dopamine, norepinephrine, and epinephrine.
Have you done any genetic testing yourself?
Oh yeah, for sure. Are you kidding?
Yeah. Did you go through what is it, Prometheus? Did you use that at all?
I did it years ago. I did 23andMe back when they had the full plates, and so. I now time has evolved and stuff. 23andMe, which is still okay, but they've actually shrunk what they give you quite a bit. Back when probably, gosh, I don't know, 4 or 5 years ago, you got everything. They just gave you everything, which was great. So I have so much information about myself.
They gave you, so I did 23andMe as well, but I had to, at least I thought I had to put that raw data through Prometheus, and then it gave me everything.
So if you know how to read the raw data, I do not, but some people do. They know how to look up the RS number and figure it out. But I put it through a different. So I didn't use Prometheus. I used something else, Opus 23. Okay. Ralph is a master trainer for Opus 23, so he put it through that for me, and then walked me through it. And I put it through a few other things. I have a few other friends who own SNP breeder companies, and the great thing is they all said the same thing. So it was all good.
I forget who I was talking about it with. It might have been Ralph. I'm not sure. But when they go through the Prometheus, there's like 22,000 genes that they interpret. And, it was like 75% green, which is like positive, and then, like a lot of neutral, and then a few like negative. But the negative, even if it was like 10%, that's still a ton of different things. So I was looking through, I was like, I'll go through the negatives and then I'll go through the positives as if I was going to go through all 22,000. So I spent like a day just reading all these negative things. And I would highly recommend you don't do that, because it was just put a huge damper on my day, thinking I was just going to die. It was like high risk of obesity, heart attack, every possible thing. Yeah.
But remember though, I'm sure lots of your people on your podcast have said this, just because you have the gene doesn't mean it manifests, right? So as the saying goes, that your genetics loads the gun, but it's your epigenetics, it's your lifestyle, your diet, your habits, what you're exposed to that pulls the trigger. So And I say the same thing with estrogen. I have people that say, oh, I have the slow COMT. I have slow COMT. But then I test them. I test their hydroxy and their methoxy, and they're fine. The ratio between them is good. And I'm like, well, it's not manifesting in your estrogen. So you might have slow according to the report, but it's not slow in your body, or your body's figured out other ways to help you, support you. So yay body.
Right.
Yeah.
Right. And most of these things that we're talking about, it's not one gene. You know, when I say that there was the high risk of all these different things, there was also, 10 that said you were lower risk. All
Right.
these are multifactorial, and everything, a ton of things go into it. So
Right. Absolutely. So, and as the genomic research has just exploded, much like microbiome research. So there's just so much we don't know, and so much we're finding out literally every day. Like the amount of research that comes out on, when I look and check into PubMed is just
it's ridiculous.
overwhelming.
Something I was thinking of, it's I guess it's a little bit morbid, but not really. It's like, I feel like with how much is coming out now, and it's such like an amazing time to be around and to see it. I almost feel like, if somebody got polio like 1,000 years ago or whatever, you died well before, we cured it. It's almost like, oh, okay, they were just one person who did it. But imagine if like you were one of the people who died like 2 years before the cure came out. It would be like, oh my God. I feel like we're like at the age and like in this time where it's going to be kind of like right when we're getting like really old, where we have some like amazing genetic data and like things that we can do to our genes,
Yeah.
Or, like just behind it.
Like the next generation. It'd be great for our kids and our kids,
Right,
our grandkids, like, dang it.
Yeah, we were so close.
Yeah, we'll know so much more.
We'll be able to stop aging like right when we're like 90. And it's
Right.
like, we just can permanently be 90.
Right. Where everyone else will be permanently whatever.
Yeah.
They're nice, healthy young age.
So I like to end on kind of like an actionable step for people. And we talked a lot about hormones and I guess manipulations and things. So if somebody is feeling like they have a hormonal issue, and people could feel fatigued for a million reasons, they could feel a lot of these symptoms for a million reasons, they're feeling just kind of like off, where can they start to even like try to get a hold of this and really sort out all their hormones?
So first of all, much like you, I'm a big fan of test, don't guess. And so if you're a woman listening to this and you are a cycling woman, then make sure you're testing at the right part of your cycle. So most of the hormones that were estrogen, progesterone, we want to catch on day like 19, 20, 21 of a typical 28-day cycle. And the reason is that your progesterone doesn't come out until the second half of your cycle. So if you go and get your hormones tested on day 6 or day 8, and your doctor says, oh, your progesterone's low, it should be low. It should be low then. It's not until the second half that it comes up. So I always tell women, like, make sure, don't waste your time and money until you know what your cycle is. Count, with day 1 being your first day of bleeding, actual bleeding. Some women spot and then they bleed. And then I'm like, count forward, day 19, 20, 21, then get your estrogen and your progesterone tested. And then when it comes to thyroid, I say make sure you're try to request the big picture, like what you got. Try to get your TSH, but also get your free T3 and your free T4, and try, ask, see if you can get your reverse T3. And if you have autoimmune in your family, or if you've already been diagnosed with autoimmune, get the thyroid autoimmune markers. And this applies to men too. I think people forget. I'm glad you brought up thyroid, because I think people forget men can get thyroid stuff as well. We commonly think of it as a female thing. And then men, when you get your testosterone drawn, get it drawn first thing in the morning, because testosterone is supposed to be highest in the morning, right? For certain reasons. Testosterone rises to make other things rise. So don't get your testosterone drawn at noon. Go right when the lab opens, and let's see what your ability is when it's supposed to be at its peak. But I have this all the time. Men are like, oh, I had a break and I just ran to the lab in the afternoon. And I'm like, no. Got to do it at a certain timing. So test, but make sure you're testing the right time of day or the right time in your cycle if you're a woman, a cycling woman, and then go from there. Then you'll have the right data to work with.
Awesome. So basically, don't just assume that this symptom means this problem. Go get things tested.
Because like you said, fatigue, somebody might hear this and say, oh, I have fatigue, it must be thyroid. But I mean, if you type in fatigue, and if you just type I have fatigue in Google, you'll probably get, 6 million searches and reasons as to why you have fatigue. Everything from, just stress and all the way to nutrients, like iron, B12, B6, just hormones, cortisol, thyroid. I mean, there's just a million reasons for you didn't sleep really well last night, your melatonin's
Right.
too low, whatever. And so you kind of want to like at least get the basics to try to narrow it in, figure out why you're tired.
Awesome.
Or why you have whatever symptom you have.
Great. Well, Dr. Carrie Jones, thank you so much for lecturing everybody, including me, today. Where can people find you? I know you're on Instagram. Where else?
I am on Instagram. Yep, it's dr.carriejones, dr.carrie Jones. And then at Dutch Test, so DUTCH test, dutchtest.com, which is a hormone test. So you can find me in both those places.
Great. All right. Well, thanks again.
Yeah, thanks so much.